Thank you very much for having me. I had the pleasure of discussing the emergence and evolution of novel immunotherapeutic treatments for acute myeloid leukemia at this year's SOHO meeting. I presented virtually. Unfortunately, this year's meeting was virtual, but I think we covered a lot of important ground. In terms of immunotherapy, I do feel that the field of myeloid malignancies and acute myeloid leukemia is moving forward. There is currently one approved immunotherapeutic in AML, and that's gemtuzumab ozogamicin, which is a CD33 antibody drug conjugate. And it's approved in multiple settings. It's approved in combination with induction chemotherapy, as monotherapy in patients who are not eligible for intensive therapy in the upfront setting, or as monotherapy for relapsed refractory AML. In the practical setting, we use gemtuzumab ozogamicin, at least I do, most commonly in patients who have core binding factor or favorable risk cytogenetics in combination with intensive chemotherapy, because in this group, at least in meta-analyses and larger data sets, it does appear that there is a particularly strong benefit to the addition of the antibody drug conjugate, but the drug can also be used in other settings, as I mentioned. In terms of new drugs that are emerging, there are multiple targets on the surface of leukemic cells that can be taken advantage of. These include CD33, but also CD123, CLL1, CD70, CD47, FLT3. All of these are potential targets for immunotherapies in AML. In terms of other drugs that are currently being studied, there are antibody drug conjugates and bispecifics targeting all these, most of these targets actually. There is a drug from the company ImmunoGen that is looking at an antibody drug conjugate for AML, and has been studied in relapsed refractory AML, as well as another rare myeloid neoplasm, BPDCN. There's promising data of multiple responses, reductions in blasts, including several complete remissions. The drug that's perhaps furthest along in terms of bispecific technology in AML is flotetuzumab, which is a DART bispecific compound. That drug has shown a particular promise in clinical trials in patients who have primary refractory disease or have experienced early relapse of AML. These patients, this group of patients, has a particularly poor prognosis, as you can imagine, in general, and to have a somewhat promising response with this DART compound is promising. We'll have to see what subsequent study and regulatory review of this drug will ultimately reveal, but at least based on what we have seen so far, I think the data is intriguing. There are also other intriguing targets, CD47 and CD70, that are being explored in AML, particularly with naked antibodies. CD47 is a don't eat me signal for macrophages on the surface of cells. And the antibody against CD47 blocks that signal, allowing macrophages to target and hopefully eliminate myeloid blasts. Magrolimab is this antibody. It at least as monotherapy, it has very modest activity, but when you combine it with a class of drugs called hypomethylating agents, it seems to show particular efficacy in AML, with the majority of patients experiencing suppression of blasts and marrow responses in those in whom it has so far been studied. There is specific interest in a group of patients with p53 mutations that have been historically very challenging and resistant to various therapies we've tried. Even in this group, at least in limited numbers so far, magrolimab in combination with hypomethylating therapies, again, appears to be particularly promising. CD70 is another target that has garnered some degree of interest. Antibodies are being developed and have been developed against CD70, and in early studies seem to show activity. Studies are ongoing, and we shall see if CD70 also proves to be a promising target in terms of therapeutic efficacy. Thank you so much for your attention, and I do hope that this field of immunotherapies does continue to move forward for our patients with myeloid malignancies and AML.